My name is Dr. Geoffrey Bergman. I'm an attending physician here at the Weill Cornell Medical Center and affiliated with the New-York-Presbyterian Hospital. I think that one of the really very good points about our program is it is truly a multidisciplinary group of people. We're a relatively small group. We have a very robust program now. And we're a group of physicians and physician's assistants and ancillary staff who actually do talk to each other and carefully consider every patient and all aspects of each patient so that we can give them the best possible care and really take care of them. Well, we really started to call ourselves a structural heart program with the advent of transcutaneous aortic valve replacement, the TAVR program. We started quite early in the partner program with the Edwards valve research trials, and we've expanded that to include other percutaneous procedures for the aortic valve, for other valves in other positions, and we've incorporated the work we do with other structural defects like septal defects, sometimes treating paravalvular leaks, and the MitraClip procedure, and we've been able to enroll that all into one program where everybody works together to help people. Clinical trials are a very important part of the program because they keep us completely up to date. They force us to be right up there with everybody else and looking at the latest information available, not only about the products, but about which particular patients the products should be used for and how to use them and how to, particularly sizing and an approach to how these devices might be put into patients. And this, of course, then trickles down to the routine clinical use of similar devices, where we have a better feeling for how to risk stratify and to choose the right device for each particular patient. We are very lucky that we are going to be involved at an early stage in percutaneous devices to treat the native mitral valve. We already have some experience with treatment of the pulmonic valve, and future developments will move into areas, the tricuspid valve in particular, which is a very challenging territory for device treatment, for any kind of treatment. And I think there will be continuing development of all of these products to try to produce truly minimally invasive treatments for all kinds of valvular heart disease. We have to be very careful to show through clinical trials that these percutaneous devices are truly as good as the surgical devices that are already available. And the current trials in low-risk patients are going to be crucial to the further development. But we see low-risk patients being not only low risk for surgery, but they should be low risk for percutaneous treatments. And I think that this will allow us to do more patients. I think that patients will be done with shorter hospital stay, and indeed, maybe one day we will be doing this on an ambulatory basis. Come in the morning, have your valve done, and go home later the same day, and avoid any kind of stay in the hospital at all. Well, we've had very good support from the administration here, and we have been able to put together over the last few years a strong team of people in our valve center. We have physical space, not enough I might say, but we have a physical space, and we have a lot of resource allocation that has been made available to us. And we have very good help from the CT department, the echo department. Everybody is working together to make this program really work. Well, I think we have really very good results, and it's a very robust program, particularly with reference to the aortic valve program. We've had extremely good results from our patients with relatively low stroke rates, relatively low vascular complication rates, and the patients we have enrolled into research trials, we've done extremely well in the partner program with the Edwards valve in particular.